Every 72 seconds, another older adult in this country receives a diagnosis that changes everything. By the time you finish watching this, nearly 18 more families will be sitting in a doctor's office, trying to make sense of words they never expected to hear. And for too many of them, the real cause had nothing to do with their genetics or their age. It was sitting in a pill organizer on the kitchen counter, prescribed by someone they trusted completely. I quote Dr. William. Across nearly 2 decades of clinical work, I've witnessed this pattern repeat itself with heartbreaking consistency. A person who spent their entire life mentally sharp, organized, and capable begins to unravel slowly. Faces become unfamiliar. Conversations dissolve before they're finished. Simple routines that defined their daily life suddenly feel impossible. The people closest to them shrug and say what everyone always says. This is just what aging looks like. Except it isn't. Not always. Not even most of the time. What I've seen, and what the research keeps confirming, is that a hidden pharmaceutical burden is quietly stealing cognitive function from millions of seniors, while the medical system looks the other way. There is a category of medication, ordinary and commonly prescribed, that can accelerate memory deterioration dramatically within 12 months of regular use. The people taking it are rarely told. The decline gets misattributed, and the window for recovery narrows a little more each month. Today I'm going to walk you through 9 specific medications most strongly linked to accelerated memory loss and cognitive decline. We'll move from the most commonly overlooked to the single greatest threat I've identified in my years of practice. Pay close attention when we reach number 3. It's dispensed to millions of older adults for a condition that sounds almost trivial, and evidence suggests it may be physically altering the structure of brain tissue responsible for memory formation. Before we begin, I'd like to ask you something. Leave a comment below telling me your age and which medications you're currently taking daily. I genuinely go through those responses, and what I learn from this community directly influences which topics I address next. Let quotes begin at number 9, and remember, its position on this list doesn't reflect how widely it's used, because this one is virtually everywhere. Number 9 is diphenhydramine, the active ingredient inside Benadryl. It's marketed for allergies, for nighttime sneezing, for colds, and most commonly among older adults, for sleep. No prescription required, low cost, familiar packaging. Most people treat it as harmlessly as a glass of warm milk. The brain experiences it very differently. Diphenhydramine belongs to a class called anticholinergics, a category defined by one specific mechanism. They interfere with acetylcholine, the neurotransmitter your brain depends on for encoding new memories, sustaining attention, and maintaining mental clarity throughout the day. In younger brains, this disruption is temporary and manageable. In aging brains, which already produce diminishing quantities of acetylcholine, that disruption lands with far greater force. The region most vulnerable to this chemical interference is the hippocampus, the compact structure tucked into the medial temporal lobe that acts as the brain's primary memory consolidation center. Chronic suppression of acetylcholine activity in this region doesn't just slow memory formation. Over time, it may contribute to measurable structural changes. In my own patient population, I've followed individuals who used a nightly antihistamine for 3, 4, 5 years without interruption. The cognitive drift was gradual enough that nobody connected it to a drug they'd never been warned about. A 2023 publication examining older adults with sustained anticholinergic exposure found risk of dementia elevated by more than 54% compared to those who avoided such medications entirely. That's not a marginal difference. That's more than half again the baseline risk, generated by a pill sold next to the vitamins. What should you do with this information? Start by reading labels carefully on anything positioned as a sleep aid or a nighttime formula. Those products almost universally rely on diphenhydramine as their active ingredient, regardless of brand. For allergy management, newer generation antihistamines, including loratadine, work without meaningfully penetrating the blood-brain barrier, making them substantially safer for long-term use in older adults. Quote, modify your current regimen independently, but don't continue assuming that shelf availability equals neurological safety. Those are two very different things. Number 8. Lives at the intersection of digestive comfort and nutritional depletion. Proton pump inhibitors, which include omeprazole and esomeprazole, among the most recognizable drug names in pharmacy history, are prescribed to suppress acid production in the stomach and manage conditions like gastroesophageal reflux disease and chronic heartburn. They work well enough that people remain on them indefinitely, sometimes for 10 or 20 years, because stopping feels worse than continuing. What patients are almost never told is what happens downstream of that acid suppression. Gastric acid is not simply a source of discomfort. It is a biochemical tool your body requires to extract certain nutrients from food. Chief among them is vitamin B12, which maintains the integrity of neural pathways and supports cognitive function at the cellular level. Extended PPI use predictably depletes B12, alongside magnesium and calcium, two minerals that regulate neuron firing patterns and electrical signaling within the brain. When those resources are insufficient, neurons misfire. Signals become unreliable. The resulting confusion and memory lapses can be clinically indistinguishable from early neurodegenerative disease, which means people are sometimes diagnosed and treated for conditions that are actually pharmaceutical side effects in disguise. A substantial study published in JAMA Neurology examined more than 73,000 patients aged 75 and older and documented a 44% elevated dementia risk among consistent PPI users relative to non-users. More recently, research has also linked PPI use to increased cerebral accumulation of amyloid beta, the protein most associated with Alzheimer's pathology. The conversation worth having with your physician centers on whether continued daily use is genuinely necessary or simply habitual. Many patients can transition successfully to H2 receptor antagonists, like famotidine, which suppress acid through a different and less systemically disruptive mechanism. There are also evidence-supported natural interventions, including deglycyrrhizonated licorice extract, that can provide meaningful symptom relief without chemical interference with brain nutrition. Duration and dosage should always be minimized wherever possible. Number 7 addresses something deeply personal. Oxybutynin, marketed as Ditropan, is prescribed for overactive bladder, a condition that causes sudden, urgent, and sometimes uncontrollable urges to urinate. For many seniors, the condition dictates where they go, what they plan, and how they move through the world. The relief this medication provides is real, but what's happening on the other side of that relief deserves far more attention than it typically receives. Oxybutynin operates through the same anticholinergic mechanism as diphenhydramine. It suppresses acetylcholine activity, and critically, it crosses the blood-brain barrier with considerable efficiency, meaning its effects are not confined to the bladder. They extend directly into the neural architecture most responsible for learning and memory retention. Research published in the British Medical Journal in 2019 followed adults over 65 who had used potent anticholinergic agents, including oxybutynin, for extended periods exceeding 1 year. The finding was stark. Dementia risk elevated by 49%, nearly 1 in 2. And the overwhelming majority of those patients received no counseling about cognitive risk when the prescription was written. The fog that develops is slow and unspectacular. Missed appointments, misplaced objects, the middle of a sentence gone before it's completed. Spouses and adult children observe these changes and reach for the most available explanation, the natural course of aging. The prescription doesn't enter the conversation until the damage is well established. Here is the important clarification. You don't have to accept this trade. Mirabegron, sold as Myrbetriq, achieves comparable bladder control through a beta-3 adrenergic pathway that leaves acetylcholine completely undisturbed. Most older adults who make the transition notice no reduction in effectiveness and meaningful improvement in mental clarity. Raise this option directly at your next appointment. Number 6 may surprise you, given how confidently it's presented as protective. Statins, including simvastatin and atorvastatin, represent one of the most commercially successful drug categories in medical history. They reduce LDL cholesterol, and substantial evidence supports their role in reducing cardiovascular event risk. I am not suggesting that anyone with documented heart disease or elevated stroke risk stop their statin based on this video. The cardiovascular benefit for many patients is genuine and significant. What I am asking you to consider is what happens in a brain that is partially deprived of cholesterol. The brain is roughly 60% fat by dry weight. It uses cholesterol as a foundational raw material for myelin, the insulating sheath that wraps around axons and enables rapid, accurate signal transmission between neurons. Reduce systemic cholesterol aggressively, and you may leave the brain working with inadequate supplies of something it continuously needs. The statins associated with the greatest cognitive risk are those that penetrate the blood-brain barrier most readily. Research published in Frontiers in Aging Neuroscience in 2023 documented a 26% higher rate of mild cognitive impairment in adults over 70 with statin exposure exceeding 3 years, with dose-dependent effects suggesting the relationship is not coincidental. What patients describe is often frightening in its specificity. A name they've used thousands of times, simply absent. A conversation from earlier the same day, completely erased. A familiar environment that feels suddenly, inexplicably foreign. Pravastatin and rosuvastatin are generally considered more brain-compatible alternatives because they penetrate CNS tissue less aggressively. If you're experiencing cognitive changes concurrent with statin use, that specific concern warrants a direct conversation with your prescribing physician about dosage reduction or medication substitution. Do not discontinue independently. Do not ignore the pattern either. Let me pause here. If this video is helping you understand something important about medications you or someone you love is taking, please take a moment to click like. It genuinely affects how many people this information reaches. And drop a comment letting me know how many medications you're currently managing. I read every single one. Back to the countdown. Number 5 is where physical dependence enters the picture. Benzodiazepines include some of the most recognized pharmaceutical names in American culture: lorazepam, diazepam, alprazolam. Prescribed primarily for anxiety disorders and insomnia, they enhance the effect of GABA, the brain's primary inhibitory neurotransmitter, creating rapid sedation and anxiety relief. The initial experience is often described as transformative. Panic that was previously unmanageable becomes tolerable. Sleep that had been impossible arrives. The medication feels, at first, like a solution. What 6 years of follow-up data published in the British Medical Journal revealed in 2022 was more troubling. Among more than 8,000 seniors tracked over that period, those using benzodiazepines beyond a 3-month threshold carried a 51% elevated risk of Alzheimer's disease. Longer-acting formulations appeared especially damaging because they accumulate in lipid-rich tissues, including brain tissue, over time. The mechanism involves a progressive chemical quieting of cognitive architecture. Processing speed diminishes, mental flexibility decreases. Many patients describe a sense of moving through life at a remove, as though a layer of gauze has been placed between themselves and genuine engagement with the world. This is not relaxation. This is suppression. The withdrawal dimension makes this category particularly dangerous to address without proper medical support. Abrupt discontinuation of a benzodiazepine in a long-term user can precipitate severe agitation, seizures, and physiological crisis. Any reduction must be gradual, carefully planned, and supervised by a physician experienced in the process. Alternatives exist. Buspirone addresses anxiety without producing sedation or accumulating cognitive debt. Cognitive behavioral therapy approaches specifically designed for sleep and anxiety disorders have demonstrated durable outcomes without the risks associated with pharmacological management. These aren't inferior substitutes. For many patients, they're superior long-term solutions. Number 4 is prescribed as a solution to 3 different problems simultaneously. Amitriptyline, sold as Elavil, is technically an antidepressant, but it's more commonly used today for neuropathic pain management, chronic sleep disruption, and migraine prophylaxis. Its versatility made it a staple of clinical prescribing for decades, and it remains widely used despite the availability of newer options. The mechanism that makes it effective for those conditions is also what makes it dangerous for the aging brain. Amitriptyline is among the most potent anticholinergic agents still routinely prescribed. Its suppression of acetylcholine activity is aggressive, and with sustained use at even modest doses, the cognitive consequences become less a risk and more an anticipated outcome. The 2015 JAMA Internal Medicine study involving more than 3,400 adults aged 65 and older remains one of the most cited findings in this space. Among those with the greatest cumulative anticholinergic exposure, amitriptyline being a primary contributor, the risk of dementia over a 10-year observation period was elevated by 54%, and nearly none of those individuals had been warned. They were given the medication for pain or for sleep. Months later, they began noticing that language was becoming less accessible, that retention was unreliable, that concentration required effort it never used to require. They accepted these changes as features of their age, rather than effects of their prescription. The alternatives are well established. Duloxetine and gabapentin both address neuropathic pain through mechanisms that don't compromise acetylcholine function. Low-dose doxepin is substantially gentler on this neurotransmitter system for sleep applications. For mood, sertraline and escitalopram offer far more favorable long-term cognitive profiles. The conversation with your physician is worth initiating. Number 3 is the one I specifically flagged at the opening of this video. Paroxetine, sold as Paxil, occupies an unusual position within the antidepressant landscape. It belongs to the SSRI family, which is broadly considered one of the safer pharmaceutical categories for older adults managing depression and anxiety. That general reputation has extended to paroxetine in ways that the specific pharmacology doesn't support. Because paroxetine is the one member of the SSRI class with meaningful anticholinergic activity, every other consideration that makes SSRIs preferable to older antidepressants applies to sertraline, escitalopram, fluoxetine. It does not apply equally to paroxetine, whose activity at the muscarinic acetylcholine receptor introduces the same class of risk we've been discussing throughout this entire list. A comprehensive review published in Frontiers in Psychiatry in 2021 documented measurable deterioration in short-term memory, verbal retrieval, and sustained attention in older paroxetine users within the first 12 months. The comparative risk of early cognitive impairment ran approximately 30% higher than in seniors taking other antidepressants. The clinical irony is significant. A medication prescribed to restore and stabilize mental function may, over time, be systematically undermining the cognitive clarity it was supposed to support. The solution here is relatively straightforward compared to others on this list. The American Geriatric Society has placed paroxetine on the Beers criteria, the formal compilation of medications considered potentially inappropriate for older adult use. That designation exists precisely because safer alternatives are available, and the risk-benefit ratio in seniors is unfavorable. If you take paroxetine, a conversation about transitioning to a non-anticholinergic alternative is worth prioritizing. Supporting B12 and B6 status nutritionally can provide additional protection during any transition period. Number 2 is where the situation becomes ethically complicated. Antipsychotic medications, including quetiapine, risperidone, and olanzapine, were developed to manage severe and often debilitating psychiatric conditions. The pharmacological potency required to address schizophrenia and acute bipolar disorder is substantial. Today, a significant proportion of antipsychotic prescriptions written for older adults have nothing to do with those original indications. They're written off-label for insomnia, for mild agitation, for the behavioral expressions of confusion that accompany dementia. In facility-based care settings, they're sometimes used primarily because they make patients easier to manage under conditions of staff limitation. The Lancet Healthy Longevity Study, published in 2022, tracked more than 25,000 older adults, and found that antipsychotic exposure for behavioral symptoms was associated with a 71% acceleration in cognitive decline within 12 months, even among individuals with no prior dementia diagnosis. These medications also carry elevated risks of cerebrovascular events, cardiac arrhythmia, and severe sedation that contributes directly to fall-related injuries and hospitalization. The mechanism of cognitive harm centers on dopamine suppression. Dopamine is not merely involved in mood regulation. It is foundational to executive planning, focused attention, and working memory. Reduce its availability substantially, and you produce a state of cognitive flatness that families observe as a kind of gradual disappearance of the person they knew. If someone you care for is taking one of these medications, the essential first question to put to the prescribing physician is not about dosage. It's about indication. Why was this started? What specific symptom is it addressing? Are there non-pharmaceutical interventions that haven't been adequately explored? Structured daily routines, environmental noise reduction, identification and treatment of undertreated pain, and careful attention to sleep-wake cycles can resolve a substantial proportion of behavioral symptoms without pharmacological sedation. When medication is genuinely required, the guiding principle should be the smallest effective dose for the defined shortest duration, not open-ended maintenance. Families deserve to know what these medications may be doing to the brains of people they love. Too often they find out too late. And now, number 1. Number 1 is not the name of a pill. It has no marketing campaign, no package insert, no pharmacy label, and it may be responsible for more cases of preventable cognitive decline than any single medication in existence. Number 1 is anticholinergic polypharmacy, the cumulative, compounding, unmonitored burden that accumulates when a person takes multiple anticholinergic medications simultaneously, while no one calculates what they're adding up to. Polypharmacy describes the condition of managing many medications at once. Anticholinergic burden describes the aggregate suppression of acetylcholine signaling when multiple agents with this mechanism operate in parallel. The distinction matters because the combination is not merely additive, it is synergistic. Individual medications that might each produce only modest cognitive effects in isolation can combine to produce outcomes that are severe and clinically significant. Consider a scenario that appears in my practice with regularity. An older adult uses diphenhydramine nightly for sleep. They take oxybutynin daily for bladder management. They take amitriptyline for a long-standing nerve pain condition. None of their physicians has examined the combined anticholinergic profile because each prescription originated in a different clinical context. Nobody is tracking the total. A study published in Age and Aging in 2022 examined more than 280,000 older adults and found that those carrying the highest anticholinergic burden were 120% more likely to develop dementia over a 10-year follow-up period, double the baseline risk. And the vast majority had no awareness that the medications they were taking belonged to this category, because nobody had told them. When acetylcholine is simultaneously blocked from multiple pharmacological directions, the consequences extend beyond simple cognitive slowing. Neural pathways that are insufficiently stimulated begin to weaken. Synaptic connections reduce in number and efficiency. The brain progressively shifts toward a hypofunctional state that, on standard cognitive assessment, mirrors the presentation of Alzheimer's disease closely enough that misdiagnosis is common. Here is what I need you to hold on to as you finish this video. Medication-induced cognitive decline is frequently reversible. That is the most important sentence I've said today. If the source of harm is identified early enough, if the pharmacological burden is reduced systematically and under medical supervision, many patients regain meaningful cognitive ground within weeks to months. The brain's capacity for recovery, given the opportunity, is consistently underestimated. What creates that opportunity is not a new prescription. It is a comprehensive medication review. Deliberate, thorough, and conducted with a physician or clinical pharmacist who is willing to look at the entire picture at once. Every prescription, every over-the-counter product, every supplement, the complete anticholinergic burden, calculated using validated scoring tools, problematic medications identified, safer alternatives introduced wherever possible, and then the brain given the biochemical space it needs to begin recovering. This is not complicated medicine. It is careful medicine. And it may be the single most impactful intervention available for preserving cognitive function in aging adults who are currently being harmed without their knowledge or consent. I want to hear from you now. Of everything we've covered today, which medications are part of your daily routine? Have you noticed changes in your memory or mental sharpness since starting something new? Write it in the comments below. Commit to requesting a medication review. Your comment may be the thing that gives the next reader permission to do the same. One more thing before you go. Your medicine cabinet holds some of the answers, but your body is communicating through other channels as well, ones most people have never learned to read. Your fingernails carry visible markers that can indicate changes in kidney function, blood composition, and neurological status years before more obvious symptoms develop. In the next video, I'll show you exactly what to look for and what each sign means. 4 specific patterns, worth 2 minutes of your attention tonight.